delighted to welcome Dr Helen Thomas, Hampshire-based GP, who is going to be introducing her clinical training module today and a new screening tool. We've been absolutely delighted to work with you and your clinical training module, Helen. Can you tell us a bit more about it?
Hi, yeah, lovely to talk to you this morning, Rebecca. So the training module has come about because having reached out to health professionals for safer screens to try and find out how we could get information out to the general public, it became clear that we didn't currently have a sort of a system to inform our healthcare professionals. The more I was reaching out to people, specifically across Hampshire and the Isle of Wight, primary care, secondary care and community settings, realised actually there was very little awareness of this problem, let alone a robust pathway for getting information out to health professionals and the public.
I couldn't agree more with that, Helen, and it's such an important thing to communicate, isn't it, to professionals? How did you find it was received when you went out to all these various different contacts?
Yeah, it's been fantastic, actually. I think, people have been really welcoming. Everything's been very well received. I think at the heart of it as health professionals, we really want to do the right thing. We want to do the best thing for our patients. And actually, the patient group we're talking about is a really vulnerable group. It's children and young people, and and their mental health. And we know that this has huge implications for our young people growing up, growing into young adults, and how they function in society. You're very well aware of the mental health crisis that we've got at the moment and the increasing concerns from all healthcare professionals across the board.
Yep, so true. And how would you like clinicians and health professionals to use this training that you're about to deliver? How would you like them to approach it?
I'd love them to just be enthusiastic, and I'd like them to be interested. I think for some people, this might be brand new. They might not even have a whisper that there are risks associated with too much device use and what the concept of digital harm. For others, there will be an awareness of some of those harms, or that there are some sort of screen time guidelines. So what I would really love is that people approach it quite open-mindedly to see what they can learn, to see how they could benefit themselves and their patients, and to really, give us feedback as well. We want this to be used. We want it to be user-friendly, and we want it to facilitate good outcomes for these young people that we're using it with.
Fantastic, Helen. Well, I'm sure you're going to empower and educate us all.
Thank you, Becky, for the introduction. So yes, I'm Dr Helen Thomas. I'm an NHS GP and the author of this Smartphones and Digital Health Harm training module. As health professionals, it's really important that we have up-to-date awareness and information about emerging harms of health, not just to our children and young people, but also to adults. Specifically, though, this module is about raising the awareness of the risks to physical, mental, developmental and safeguarding harm for our children and young people because of smartphones. I think it's really important to know about where this has all come from. And if we have a look at this, then back in the early 90s, we started with desktop computers and desktop messaging apps, but then we had very rapid growth of the technology. So the beloved Nokia 3210 that many of us will recognise. Wi-Fi enabled us to start moving around with devices. We then got more sophisticated handheld devices. The first iPhone in 2007, followed rapidly by the app stores, further advancements in wireless networks, more and more exciting products that have led us to where we are now. And that is social media on every device that is with us, but particularly with our children, up to 24 hours a day. And really, herein lies the problem. These devices are fantastic for mature-brained, busy adults, helping us to live complex digital lives. But this was never looked at as appropriate for children, and the evidence we now have tells us that for children, it is developmentally damaging. And it doesn't just give our children access to the internet, it gives the whole of the internet access to our children. And we do know that parents try and put controls and try and moderate the use that the children have to keep them safe. And for many people that works, but we know that there's a large proportion of children that are able to get round their parental controls and then are able to access and to view harmful content that has a huge bearing on their well-being. Our children are very tech savvy, but they're also very insightful about their mental health. There was a very large study released recently that looked at the opinions of the Gen Z generation and their opinions on smartphones and their health. And it was really telling. So over half of Gen Z think that young people should have social media banned for the under 16s. 62% of them thought that social media now does more harm than good. 84%, a staggering number, get round parental controls. About a third of them know how to change the controls, and about a quarter of them have a second device so they can continue their internet viewing unrestricted. And over 3/4 think that social media has become more addictive in the last 5 years. And if we look at further data that's available to us, so generation isolation was a study of over 5,000 secondary school aged children, and they were asked what they did outside of school. And I think the really worrying and important data here is that over 3/4 of children are spending their free time on screens. Of that, about a quarter are small handheld devices, their smartphones. Most of them are spending this time alone in their bedroom. Nearly half of them are reporting feelings of feeling very lonely, very anxious, and over half of them would like support to reduce the amount of time that they are on their screens. We have to ask the question, what is it about these devices that means that our children are so desperate to give up almost every hour of their spare time to be on them? And it's because they are brilliantly addictive. Trillions of dollars have gone into the development of these devices, the social media algorithms, in order to keep us scrolling. There's a saying that if you can't see what the product is, you are the product. For many of us, scrolling on social media is free, but this is coming at a cost, and it's a huge cost to our children. If we look at applying addiction criteria to the way that people use their devices, we can actually see that 1 in 4 children show addictive behaviours towards their smartphone, and 1 in 10 show the same addictive behaviours towards social media. Now, addictive behaviour isn't just the amount of time that someone's on a device, it's the feelings of desperation to be on that device, it's the prioritisation of using that device over every other aspect of their life. And this has to come at a loss of something. And we know from teachers, from parents, families and educators and health professionals, this is coming at the loss of social interaction, coming at the loss of real world interaction and connectivity. Family meals, family relationships, school learning and friendship groups. And we're also seeing an increase in more isolated activities online, bullying and gambling. And ultimately, our children are left feeling very lonely. This level of use, unfortunately, does come with very well documented harms, and the amount of evidence that we have for this is increasing every week. For physical harm, our children could be harmed from the tips of their heads to the tops of their heads to the tips of their toes. We can look at remodelling that happens in the brain. So we know that there's lower white matter integrity. Now, the white matter is required for linking and connecting information centres, for allowing reasoned and sensible decisions to happen. If you're scrolling on a phone, you don't want reasonable information. You want your dopamine hit. And over time, you lose those important connecting strands of white matter. We see increased levels of GABA, a neurochemical in the brain, and this leads to increased risk of impulsiveness as well as low mood. We know we've got an eyesight problem in our young people, and if we look at the amount of risk, it's 30% more risk of developing short-sightedness if people are on their phones more than recommended. If we combine that to all screen use, so tablets, desktops, televisions, then that risk goes up to 80%. We know that there are repetitive strain type injuries and postural injuries that are associated with over 1 hour's use a day. And obesity. Sadly, we already have an obesity crisis in our children, but the phones are adding to this. When children are on their devices, they're just not active, they're not moving. This substitution of leisure time not only has an impact on their well-being and their weight, but sadly, when they do start moving on their phones, they're more likely to be at risk of being involved in a road traffic collision because their concentration and attention isn't in the real world. And sleep, which is this most precious, restorative, brilliant function that we have, is hugely impacted by device use. We know that over 3/4 of teens are taking their phones into their bedrooms with them at night, and the children that have got their phones in their bedroom have the worst outcomes, both sleep and mental health. Talking of mental health, we know we have a children's mental health crisis. We've got global rates of teen depression, anxiety, self-harm and suicide, which have been increasing since about 2010. Interestingly, over the same time period, mobile phone use and ownership is also a global change that tracks this trend. In the following figure that's taken from Jonathan Haidt's book, The Anxious Generation, we can very clearly see that between 2010 and 2012, there was a huge spike in rates of self-harm. So what else is going on with our children's mental health? Again, in 2023, a huge study, nearly 30,000 young people were surveyed, and they were asked the age they were when they had their first smartphone. The answers were very informative. The younger someone was when they received their first smartphone, the worse their mental health outcomes were as a young adult today. We know that 1 in 5 16 to 18-year-olds tell us that at some point life hasn't felt worth living because of something that they've experienced on social media. And we've had a 65% increase in acute admissions to hospital for mental health crises and mental health problems. This is compared to just 10% for all other causes over the same time frame. We know that teens with problematic smartphone use are 3 times as likely to have depression symptoms, and they're twice as likely to have anxiety symptoms. And we know that feelings of depression and anxiety are independent risk factors for developing mood disorders, self-harm, and suicide. What is it that our children are viewing on their smartphones that is leading to this mental health crisis? 75% of UK 15-year-olds have been sent a beheading video. So Rachel D'Souza, our children's commissioner, was talking to young people, and she posed this question to them: that over 3/4 of our teenagers have been exposed to beheading videos, I'm afraid is a fact that I'm unable to understand. 90% of our girls and 50% of boys tell us they are sent explicit images a lot. And there's been a 12-fold increase in child sexual abuse material that is generated by the child in 3 years. And with increasing numbers of online grooming, so an 82% increase. And those are just the cases that we're aware of. And again, 94% of our UK 14-year-olds have seen pornography online. The average age of this is just 12. Really worryingly, the type of pornography that we're aware that comes up on children's feeds or is shared thoughtlessly in messages is what is classed as Category A pornography. This type of pornography is misogynistic, it's violent, brutal, and often is involving children. And children do this thoughtlessly, naively, almost innocently. They share images on WhatsApp, they airdrop, they show each other TikTok reels in the toilets at school. The images here are never unseen, and it just takes one child and one smartphone for harm to be done for multiple children. And it's not just those immediate consequences of seeing those graphic and violent images. We know that there's long-term consequences for children's health. If we look at eating disorders, we know that 1 in 5 of our older adolescent girls are reporting eating disorder-like symptoms, and 1 in 8 children of all ages are reporting eating disorder-type symptoms or body dysmorphias. We know that those children with eating disorders can go on to have long-term health problems with their bones, with their guts, as well as their mental health. And if we look again at some of those pornography statistics, we're now seeing erectile dysfunction in our young men and our teenage boys. There's been a 30% rise in the reports of this. And the difficulty is that deeply misogynistic, violent and brutal pornography that these children are accessing and beginning to view as normal is having huge impact on their normal physiology. And when our children are then sexually active in the real world, the normal physiological responses just aren't happening because it's not exciting enough for these young men. A report suggests that up to 15% of teenage boys starting secondary school have a pornography addiction. It's really important to know that sending and receiving nude or sexual texts is illegal under 18. And there's significant trauma from online sexual experiences. Even one incident can cause lasting damage, as well as having impact on future relationships. If we look at the impact now on school and development, so school has always been a place of safety. It's a place where children can come together, they can be educated, but they also learn about social and human connections. But here again, we see huge disruption because of the smartphones. We know that children can have up to 350 notifications daily on their phones. Can you imagine the level of distraction and the lack of concentration that pull must have on them? And teachers tell us playgrounds and corridors are quiet. We're seeing reduced social interactions, poor eye contact, and reduced empathy. We know that 1 in 5 experience cyberbullying. And interestingly, although these statistics aren't hugely different from what we would call traditional or playground bullying, the difference here is if that child experiences cyberbullying, takes their phone home, takes their phone to bed, that child is never away from that bullying and from that impact. Gone are the days where you could leave the school gates, come back home to the safety of your family, restore, reboot your resilience, and come back to face another day. This can be carrying on for 24 hours a day. And if we look at the maths and English and the PISA scores, these have been reducing globally since 2012. We know that schools that have more permissive policies, so not seen, not heard, or off in the bag, still show reduced student concentration and still offer students opportunities to be disappearing out into the toilets, to be checking their notifications and sharing TikTok videos and reels with each other. We talk a lot about social inequalities and ensuring that education and social values are equal for all. We know that some of the worst performing students are impacted the most with these smartphone difficulties. But what's really positive is where smartphones are taken away, it's these students that actually gain the most benefits. We know that there's about equivalent of an extra hour a week to learning when smartphones are removed and good restrictive policies are in place. We also know that schools that have robust restrictive smartphone policies often get grades in GCSEs 1 to 2 grades higher than schools with more permissive policies. But even before we've got to school, we know that there are problems with our little ones' development. 33% of children starting Year R this year were not school ready. This was a very large study done by Kindred Squared, and really was quite worrying about the state of our little ones. So, for example, a quarter of them weren't toilet trained, and over a third of them couldn't follow simple instructions, for example, to get dressed or to feed themselves. And teachers are worried. Nearly half of the teachers think that this has got worse since last year. About half of the teachers think that parents spend more time on screens than engaging with their child. And they tell us that seeing parents greeting their children glued to a smartphone is not an uncommon sight in the playground. And over half of teachers think that their Year R children exceed the maximum recommended screen time guidelines of 2 hours a day. So we've heard an awful lot about the physical, mental and developmental harms. I think what's also really important, and we'll come on to now, is some of the very significant harms that can happen regarding exploitation and sexual crimes. Now, obviously, some of the next data that we need to go through is a little bit more graphic and may be disturbing. So this does come with a preemptive warning. And if this causes any distress or you feel that you want some additional support with this, then all the resources at the end are able to offer you that. So cybercrimes can be categorised into exploitation, grooming, pornography and sexual images, violence and radicalisation. Exploitation, or sexploitation as it's more often referred to, is where children are asked to provide initially innocent images, but then increasingly sexual and graphic images, and then these images are used against them in order to keep them providing further graphic images. We know that there's nearly a 20% increase year on year, and in 2023, 176 cases were identified in the UK. We know that in this type of crime, it's boys and young men who are most affected. 91% of those cases were boys, and 60% of them were 16 and 17-year-olds. And sadly, suicide in these cases is not uncommon due to the overwhelming burden of guilt, shame and hopelessness that the position finds these young men in. Of these cases, 7% of these were classed as Category A pornography. And again, I'll remind you that this is the most misogynistic, brutal and often violent type of pornography and images. Grooming is the creation of a fake relationship that, again, is often used to exploit images, relationships, and sexual favours out of young people. Often these relationships are formed over weeks, months, if not years. We've seen an 89% increase in online grooming in the last 5 years, and we had 7,000 reported cases in 2024. Compared to sexploitation, grooming is often female victims, and 81% involves younger girls. And we know that social media is the most widely used platform for this, and 48% of the cases were found to involve Snapchat. So pornography and sexual images, the bottom line is it is illegal for anyone under the age of 18 to take, own, share, distribute or receive indecent images. If images are brought to the police's attention, an investigation does take place. But often if there's no evidence found of exploitation, manipulation or coercion, then the case doesn't proceed and the young person may be issued with what's called an Outcome 21. This recognises that a crime was committed, but that no further public action or prosecution will take place. However, this Outcome 21 may stay on the child's criminal records. It may be available to future employment checks or DBS checks, so it may well have implications for that young person as they try and have an adult career. We've had a 65% increase in images that are generated by the child. And we know a lot of this is due to the front-facing cameras that allows selfies and selfie videos. In 2023, there was a total of 1.6 million images identified of child sexual abuse material that is self-generated. And the use of AI to doctor and alter images is a real worry. So in October 23 alone, 3,000 child pornography images that were generated by AI were identified. So sometimes that very innocent photo of a child eating an ice lolly can be adapted, can be changed and be sent around the world in a very different format. Violence and radicalisation is also a growing concern. In the UK Prevent Programme report last year identified nearly 7,000 cases of young people who'd been exposed to online extremist content. Nearly half of that was far right-wing violence and inciting hate crimes against others. And within that, 40% were secondary school-aged children, 11 to 15-year-olds. 1 in 5 arrests in 2023 were for terrorism-related offences, and nearly 1 in 5 children involved were 12 to 13 years old. Over half of the 7,000 people referred to counter-terrorism are children. Matt Jukes, who's the head of the UK counter-terrorism organisation, said, "You have the combination of social media and enclosed messaging apps, and they've never seen 12-year-olds and 13-year-olds exposed to the things that they are now. Social media and messaging apps are impacting homes, communities, and society." And it's not just the content that our children are able to experience and be encouraged, but it's also the accessibility of harmful content and harmful weapons. And we see knife crime continues to rise, with 20,000 cases reported in 2023. 262 murders were due to knife or blade assault last year, and 1 in 5 of the perpetrators were under 25. There's a rising trend of online purchases through social media and messaging apps with apparently zero regulation. Ronan's Law came into play in early 2025. And the tragic story behind this is that Ronan Kanda was a 16-year-old schoolboy who was murdered by school friends in a tragic case of mistaken identity. However, within that murder, ninja swords and machetes that were purchased online and picked up from a post office only hours before were used in his attack. One of the perpetrators had amassed over 30 different knives and blades over the few months preceding, all being sent to the same post office, none of those causing any alerts, raising any alarms, and no age checks occurred at any point. Talked an awful lot about some of the really worrying data and evidence that we have that the smartphones can cause harm to our children. I think it's really important that we do know that with the rising evidence becomes rising awareness, and there are lots of people motivated for change and trying to bring that change about. But it's really important that we work together. So there's a collaborative call for action. We need to change the scene together. We need schools to look at how they ask children to use devices. So looking and asking them to make sure that they've got good, robust, restrictive smartphone policies, to support smartphone-free childhood parent packs and campaign groups, and to encourage the use of basic phones for safety. Parents need to encourage and support each other, need to encourage and support their schools to change. Parents themselves need to model good habits and talk about screen time limits and the way that families use devices. Sadly, it doesn't look like we're going to have any central policy changes anytime soon. The ideal situation would be that we have legislation from central government to protect the under-16s, with social media age restrictions and proper penalties when these are not put in place. There does need to be clear support for smartphone-free schools from local government level as well. Our children need to be children. They're going to need to relearn how to be bored, how to go outside and play. And there's lots of groups that have lots of information about this. And then campaign groups, so smartphone-free childhood, delay smartphones, health professionals for safer screens. There's lots of people out there who are really keen to change the scene and to support parents and young people. So this is where we come on to where we as health professionals feel like we could step in and we could do something. What can we do? So the core 3 elements are education, screening and management. And I hope that you find that the slides that we've just talked about have been that education, that you're now aware of the risks and the harms. We keep this information as up to date as possible. So these are really recent findings from research papers. We're going to come and talk about now screening and then how we can support young people. And really, we should be considering the need to talk to children and young people about screen time and social media in all our consultations. But we do know that the following consultations may be particularly relevant. So sleep disturbance, new mood changes or self-harm behaviours, new eating disorders, if school have raised concern about concentration or falling grades, new headaches, or parental concerns about changes in behaviour. Now, for GPs, many of us are probably used to seeing this health intervention flowchart, the Ask, Advise and Act. So it's part of the NHS's Make Every Contact Count programme, and we often use it for smoking or for alcohol. Here we've been able to adapt it for smartphone use, and the same principles apply, and it allows us to look at opening those questions really nice and easily. So open questions, non-judgmental. Sometimes these young people will need some more encouragement to talk, and often they don't. So just asking, tell me about your smartphone and social media use. Sometimes we can preempt statements with normalising behaviour. So do you know, or are you aware of? And then you can offer to go through some simple questions to see if that young person might be at risk because of their smartphone harm. And we'll go through that shortly. Depending on their response to that, if you're able to go through the screening questions or not, then we want to put in some action. And if that young person is interested, then brilliant. We can go through and do the screening tool, which I'm going to come on to, explain the findings, and then send them information about further support. Now, in general practice, most of us use the AccuRx SMS service, and links are available to send out that information. We can also, depending on PCN availability of ours roles, have mental health teams or wellbeing or social prescribing teams. And this information has been available for all of them as well, so they can pick up and support where it's appropriate. If that young person isn't interested, much like in smoking and alcohol, it's really important that we know that we keep that door open. So it's just saying, do you know what, that's okay. If you feel things change or you want more information, then you know you can always come back to me. And I would always say, would you like the information anyway? And if they're happy to have it, do send that text. And always offer to reassess at future visits. And that clearly was the fancier slide. So just putting this into a slightly different format. So initiating the conversation, preemptive questions, and then asking if they can go further, advising about the help and support that we would like to offer, and then the actions based on interest. And this flowchart and the one preceding are both available in a PDF form that can be printed and can be shared to use as a checklist. So in paediatrics, in CAMS, in secondary care, the HEADS tool is something that I think our secondary care colleagues are much more used to using. Now, often this isn't done in one sitting, but it can be, and often, you know, the acronym can be dipped in and out of. And again, just running through this, I think it's really important, sort of sharing different tools that we use as colleagues. When I've worked in emergency departments, this is definitely something that we used, and I'd like to use it in general practice. It reminds me to check in of all sorts of different questions with our young people. So the H stands for home. It's always just important to look at family dynamics. And partly with this and smartphones is looking at the way that the whole family might use devices. E is for education or employment, so asking that young person what they're currently involved in. It allows fact-based questions, so then we can hopefully engage that young person and then open up more as we ask about some of the more personal questions. A is activities. What do they enjoy? What are their hobbies? How do they spend their free time? And really important to ask about activity levels and time outdoors, because we know this is so beneficial for their health. D is drugs, smoking and alcohol. So this is where we often get into the slightly grittier questions, and just saying that it can be normal and exploratory behaviour is really common in teens, making sure we don't judge. And then coming on to the slightly punchier questions, so suicide and self-harm. So teenage years can be really overwhelming, and I think it's really important that we just check in with our young people and, you know, really not being afraid to ask these questions. Sex, again, being inclusive and open. And then the final S, smartphones and social media. So often when I've had these conversations with young people, they're really open about getting their smartphones out, and they'll just be able to look at their user hours, and they'll tell you about that, and they're quite aware. So this is a screenshot version of the screening tool that we're about to come on to. It's a globally validated tool specifically for young people and smartphones. It's 10 questions, so nice and easy, and they're scored from a scale of 1 to 6. So you can see that the more you agree with a statement, the more likely you are to have a problem related to your smartphone use. In theory, when Quan and their team devised it, they were used cut-offs of 31 for boys and 33 for girls. Where we've adapted this, we've used 31 as the cut-off for both, because we want to make this as easy as possible for clinicians to use. And actually, even if you're quite close to the mark, having some evidence and support is just as important. So I'm going to quickly have a look at this online with you now. So this is available and the link is available for anyone to be using. I'm going to complete it as if I probably have a bit of a smartphone problem, don't we all? So I'm going to somewhat agree that I have a hard time. I have a hard time concentrating in class. Sometimes I get pain if I've used my smartphone for too long. I wouldn't be able to stand not having it. I can feel impatient and fretful when I'm not holding my smartphone. I'm often thinking about it. I'm never going to give it up. I constantly check my smartphone so that I'm not going to miss conversations. I use it for longer than I'd intended, and other people tell me that I use it too much. And you can see that when we click done, the computer does all the hard work for us, gives us a score at the bottom. We don't really worry about the percentage, and it gives us a colour box. So as you might expect from a traffic light system, red is a worry. So red tells me I'm in a high risk category and I am probably using my phone in a way that is negatively impacting me. And within that box, you can see there's extra information and support and the resources available there. If I had scored slightly less worryingly, then that box would have been amber. And if I'd scored with no risk at all, that box would have been green. All the resources are still offered within that so that you've got resources right there and then and know where you'd like to go. So coming on to the digital resource packs that we've developed, we've split these into clinician, patient and family, and then just some further support links. If we look at the clinician resources, there is the recording of this module, which you may well be listening to as at a later date rather than live. And I hope that you find this helpful, that you can dip in and out. Like I said, we do endeavour to keep the stats up to date, so this should always be the most up-to-date evidence that you can use to inform your practice. We will always have a copy of the very brief intervention checklist and flowchart. The screening tool, both the paper copy as well as the link, are also going to be available. And then looking at copious amounts of resources and referral options. So all of these resources are going to be hosted together on various sites. So Health Professionals for Safer Screens will have a digital health tab. Under that tab, you will find clinician. And if you go into there, all of those will be present in one place. We're really lucky that other partners have come forward and have asked to host these resources. So in Hampshire and Dorset, we've got Wessex Healthier Together. In Hampshire, we've got Cooth Hampshire, who are an app-based counselling service for our under 25s. And they are also hosting these resources on their websites. So these will all be in one place and easily and freely accessible for all. So that you're aware of what we offer to our patients or our families. So there will be, again, under the digital health tab, a resource for patient or families, and all of these resources will be in one place. So as a clinician, for example, in general practice, you may want to head to that resource to copy the link, and then you can send that in an AccuRx SMS message, and all of that information would then be there in one place for that family. So Health Professionals for Safer Screens have made a summary table of age screen limit, so 0 to 17. So it's a one view document. We've created a family rules checklist. Now, this is something that you can download, that families can sit down and work together. We feel it's really important, and the evidence tells us that it works best when families come together, making sure that the children's voices are heard. Our children often have some really insightful comments about how their parents use their phones. And although that might be a little difficult to hear, it's often really important for that child to recognise and hear that the parent notices what they're saying and notices their own screen time use and is willing to change. Really important as parents that we're modelling good behaviour. So Dr Susie Davis is the founder of Papaya Parents. She's a GP based in Bristol and has done excellent talks and resources for parents, families and schools. She's very kindly contributed a 10-minute video for families to look at how families can come together, look at their screen times and support each other. And that resource will be available online as well. And again, lots of resources and lots of other links. In terms of the other supporting agencies, so we've got Papaya Parents, Cooth Hampshire, Health Professionals for Safer Screens, and Wessex Healthier Together. In terms of just a brief look through some of the resources that health professionals have, we've got the 5-a-day healthier screen time limits, infographics around digital use and other things that can be done, and then we've got some slightly punchier posters about health education and harm. We do occasionally get asked the question about could smartphones be used safely for children at all. Often there will be medical needs needing to be considered. Currently, diabetes and continuous blood sugar monitoring is the only condition that uses a smartphone to alert users to risk. And clearly, where there is a medical need, we are never going to say that a smartphone is an inappropriate device to do this. We do know that children with special educational needs, autism and ADHD may have additional needs that vary greatly, and these may need an individual approach to smartphones in particular settings and situations. We do know that the evidence shows that these children are much more susceptible to dopamine and can often have much more addictive relationships with their devices. So it's really important that we pay special attention to this group. And really, the bottom line is that smartphones and social media should be delayed until at least 16 is the best advice and recommended by health professionals and researchers. However, if your family already has smartphones for your children, or you want to look at how you can adapt the way that you use them, then there are some good tips here. So clear boundaries for use. So setting restricted times and restricted areas. For example, bedrooms should always be a hard no. Meal times or around the table could be another area to consider. Devices should be used with controls and heavy parental controls. Parental controls, time limiters, do not disturb modes, keeping notifications off. You can download extra security apps. So Custodia is one that is able to be used, and checking that your child hasn't downloaded a VPN. So that's where they can download and use their own network, which allows them to bypass all existing parental controls. Parents, you can check whether they downloaded one. You can block future VPNs from being downloaded. We must replace tech time with rewarding alternatives. We can't just be seen to be taking what they perceive something fun, informative, engaging away from them. We look to put back in place outdoor activities, fun and rewarding time with families and friends, play dates, not only improving social connectivity and real world skills, but also their mental health and well-being. And again, the family plan, coming together as a family, talking about how you want to use their devices and listening and respecting each other. And as a family, again, talking about mental health and well-being, checking in on each other regularly is really, really important. Openly talking about worries and setting a culture within your family where children feel that they can come and talk to you is really vital. So thank you for bearing with me through what has been some quite hard statistics and evidence. Hopefully I have then presented to you a more hopeful way that we can be moving forward together with this. And there absolutely is a way, and many people are already doing it. In summary, we know that physical health harms can include injury, obesity, and lack of sleep, that mental health can be badly impacted due to bullying and seeing inappropriate content, that safeguarding and sexual harm are significant risks online, and that real-life childhood experiences are being replaced by indoor tech time, leading to social isolation and lonely children. We need to come together and work to act together collaboratively. We can delay access to smartphones and social media, and we can model good adult behaviours. We hope that this healthcare training will improve awareness and allow you to feel confident to identify children and young people that may be at risk of harmful smartphone and social media use. We can then use validated screening tools to risk stratify our children and young people, and then offer appropriate support in an efficient and non-judgmental manner. Limiting screen time for all, adults and children alike, increasing connections with each other, increasing outdoor activity time, and talking about our mental health will have positive outcomes for everybody. Thank you very much for your time. Please feel free to use the resources on the websites, to download them and to share them and talk about them with your colleagues. At Health Professionals for Safer Screens, we're always really happy to answer further questions and to share further information and support you in your journey about digital health. Thank you very much.